we joined together to have the web meeting for anti-COVID-19. Today, there are different countries. Here is from mainland China. Professor Zhong and me, Xue Li is also from the first hospital of Guangzhou Medical College, and also from Germany, Professor Hertz chair the Germany meeting, and another is from Italy, Dr. Covetta, and also from UK, Professor Bentham from UK, and there's also and another country from Romania, Mr. Freddy Grace, and also from the Hong Kong mainland, Dr. Bin Lei. So please, Professor Lam, you have to say something.
Hello, everybody. Welcome to this web meeting. So today's the agenda is like this. First of all, colleagues, experts from mainland China, from Italy, Germany will talk about the condition of COVID-19 in their country and also the strategy for the treatment of COVID-19. And there will be also experts from UK, from Romania, talking about the condition there. And after the presentation, we will have a Q&A session to have a hot discussion. And at the same time, we will be receiving questions online. And then by then, we shall try to address the questions based on your view on this point. And first of all, without further ado, I'd like to introduce the first speaker. First speaker is Professor Zhong Nanshan. Zhong Nanshan actually does not really need any introduction in Asia, in China. Even non-medical society knows Professor Zhong well because he is the leading figure in the war against SARS 17 years ago and also against this COVID-19. And Professor Zhong is academician of the Chinese Academy of Engineering, and he is actually the leading expert in pulmonology in China. And he will talk about the strategy for anti-COVID-19 in China, and followed by his talk, then Professor Covetta, actually as Professor Bartoloni will talk about management of COVID-19 in Italy, and followed by UK speaker, Professor Jonathan Van Tam, to talk about the condition there. And after that, Professor Li Xiyue will talk about how to do bronchoscopy safely in COVID-19 patients. And then followed by Professor Luo from the West China University. He actually worked in Wuhan for 2 months, in the past 2 months, and now he's still self-quarantined at home. And after that, I think that Professor Felix shall also talk about something in Germany or only chair the meeting. And then all the people will join the discussion part. And after that, we will try to address those questions via the internet. So now, first of all, let's invite Professor Zhong to give his view on the strategy on anti-COVID-19 in China and his wisdom for the world. Professor Zhong.
Okay, thank you, Dr. Lam. So it's a great pleasure to meet with you, our colleagues. And then I suppose in this limit time, so I would like to focus on a few points. So can I have the slides, please? Okay, I would like to talk a little bit about what's this China status at the moment in combating the new coronavirus infection. So I think that this is today's data. I think altogether it is really a great spreading, causing a pandemic in the world, all over the world, with more than 400,000 people infected, and also 18,000, more than 18,000 people now with the morphology of 4.4%. So I would like to focus on some points. First is transmission features. As you know now, everybody knows that's a very strong human-to-human transmission of this COVID-19 infection. But I would like to focus on some of the patients who, without any symptom, but actually they are virus carrier, may be very infected. I mean, contagious of that. So as you know, the role of SARS coronavirus, new SARS coronavirus is transmission. So of course, the direct contact and the main transmission role.
Okay.
There's good evidence showing the mother to child, the baby viral transmission during pregnancy. Whether they have some stool transmission, so remain to be elucidated. So, but that's the infectivity is pretty high. So we have to think about some way, like feasible, possible fecal, urine, respiratory transmission this way. So as you know that the outbreak of Diamond Princess cruise ship, so about 1/3 of the passengers infected. It's not only based on face-to-face talking and then cause such a high percentage of infection. I think that's the first paper published showing that the asymptomatic person will have some infectivity. So this is one person from Shanghai attend the meeting, visit Germany, and two of his partners worked together. And then when he flew back, in that case, flew back to Shanghai, got symptoms, and eventually 2 or 3 days being diagnosed as having COVID-19 infection by PCR. And two of them, the partners, also get infected. So I would like to say the basic reproductive number, a lot of studies showing that, but I suppose maybe close to the reproductive number, maybe close to 3, something like that. So it varies from places to places, but at least it's much higher than SARS and MERS, of course, much higher than seasonal influenza. I think the point I would like to mention is to emphasize this virus loads are pretty high in the upper airway at the first few days of onset. So of course that's a big problem. So it decreases remarkably 1 week later. So what can we tells me about these? So we have to think about that's a very high basic reproductive number, close to 3, and also a very high mortality as compared with influenza. And also that's a transmission capacity to human by asymptomatic virus carrier. This is why now in China or in Hong Kong, there's very much concern about the importer. So, and also very important is that earlier, the stage of patient onset, the higher infectivity. So this is something we are worried about. So, and also, so we should keep up clean and clear of the sure and exhaustive puke. So diagnosis, I'm not going to talk too much about that. So, but anyway, so usually we use in suspected patient, we use a real-time PCR, virus RNA. But right now in China, we started using double check and have for IgM study. And I think this is something, the method. I'm not going to talk too much about that. So now, as I remember, in Hong Kong, there's also to test the sample in saliva. So this is the real-time PCR. And this is IgM study. As you know, the IgM appeared. So IgM appeared in the here appeared. So in early stage, or something like 7 or 8 days after infection, or 3 or 4 days after onset of the disease. So the point is, we should make some differential diagnosis, and also at this time, trying to differentiate the COVID-19 infection and influenza. So this is some in China. We have been working by using some facilities trying to differentiate this two kind of disease, which is quite difficult to differentiate from the clinical part. So, and the third, I just basically pointed out about the clinical characteristics. So this is a paper that's published by our group, by Dr. Guan, and then collecting about close to 1,100 patients in 500 hospitals at the very beginning. So that at that time, the mortality is not that high, and our primary endpoint will be composite endpoint, either admitted to the ICU or invasive ventilation or death. So you can see in this clinical analysis, the mean incubation time is 4 days, from 2 to 7 days. And then a very important point I would like to point it out is, so of course the fever or cough, fatigue is most common symptom, but so in our groups, so close more than 50% of the patients were actually a fever on admission. So that's a need to be very careful to see, because fever is not the golden standard for the symptom of the this COVID-19 infection. And also people should be noticed. So of course, more than 85% of patients have a CT abnormality with GGO, and bilateral infiltration is most common, in particular distribute around the subpleural location. And the laboratory findings have found lymphopenia is very apparent index, elevated CRP, LDH, and direct bilirubin. And this is something we need to be very aware about that. This like the X-ray like this. So we actually had very important a study showing how to predict critical ill patients. So the predicted indices were around 10 points. Of course, the X-ray abnormality, age, hemoptysis, and dyspnea, unconsciousness, and number of comorbidities, and cancer histories, and neutrophil lymphopenia, and LDH increase, and increase of direct bilirubins. So we'll put this together and make a prediction whether there will be a very serious ill patient or will be mild. So in terms of the management, so I think we are now doing some study at the moment. First, lopinavir and ritonavir, the Calitra, that's first, and chloroquine and IL-6 receptor antibody, tocilizumab, and this is a Chinese traditional Chinese herbs, 莲花清瘟胶囊, and hydrogen and oxygen mixed gas inhalation, and also convalescent plasma and remdesivir. So far we have got some results. This is one presented by Dr. Chao Bin, and he have found with the primary endpoint, the time to clinical improvement, and some other. So Calitra, it didn't show some superiority as compared with the other treatment, either any kind of so-called antivirus treatment. didn't show that. So it doesn't show very effective of this kind of Calitra in the management of COVID-19. And the second is chloroquine. And before we published the, we just finished the study, and now it's going to submit to the literature. And before that, some colleagues have found the chloroquine or hydroxychloroquine as an available weapon to fight COVID-19, and they have not actually had not done the study. So actually, from our laboratory, so we have found this is actually COVID-19, and that's the target protein is from the 3D mode of chloroquine is based on this active site to 3CL of SARS coronavirus, and that the plasma concentration, if we use 500 milligrams per day, twice a day for 10 days, and the plasma concentration is this in this range, very much close to the EC50 of chloroquine against COVID-19 in the blood. So at this point, we had just finished a data showing. So we use open label, multi-center, non-randomized trial because it's difficult to make a randomized trial, and just show you the result because they are submitting this paper to the journal. The patient in chloroquine group had shown a shorter time to reach the undetectable viral RNA comparing with the control group, 3 versus 9 days, pretty good. So by the day 10 or day 14, they have higher proportion of patients have virus RNA turn into negative. So this is the percentage for chloroquine group, and this is the percentage for control group. It's much higher than this in the chloroquine group, and the duration of fever significantly shorter and in chloroquine group. This is the result, the primary result. So another is the TCM, Chinese traditional medicine, in particular, and this called the LH QW, this one. And I think we have done some laboratory study and looking at that antivirus or anti-inflammatory activity for these Chinese herbs. I'm not going to talk too much about that. We just finished a clinical trial and have a control study. And for 284 patients receiving treatment and higher overall recovery rate in the treatment group as compared with control group. This is the result. And faster symptom recovery in the treatment groups. This is 7 versus 10 days, and higher rate of important improvement of CT scan manifestations. This is the result. And there is also clinical recovery in the treatment group. But however, we didn't find a significant difference in the conversion rate to, I mean, some of the patients turned into severe status, and some, and also the virus conversion time. So that's no significant difference, although that's a tendency with tendency towards shorter of this Chinese herb, but it didn't show significant difference. That's this paper is under review. And convalescence, the plasma, let's see. This is a data as in preprint data. The feasibility of convalescence plasma therapy in severe COVID-19 patients. A pilot study is in press. We use the recover donors with the neutralizing antibody titers about 1 versus 640, and 10 patients, just 1 dose, 200 mL convalescence plasma, and primary endpoint the safety of convalescent plasma transfusion. And secondary endpoint is improvement clinical symptoms and laboratory parameters within 3 days after the transfusion. And this is the primary result. You can see both the CRA and lymphocyte and alanine, so aminotransferase and aspirate, aminotransferase, and total bilirubin. It also shows in except for total bilirubin, the other seems to be improved, lower or going down, and the lymphocyte seems to be a little bit better, and oxygen saturation is also getting better, and this is also on the time on the way for publication. And in particular, it's important as a comparison of the serum neutralizing antibody. So you can see the virus load here, and also antibody, so titers. You can see or increased, and also the serum virus loads all turns to negative. So that's the primary result. That's the before and after, And then some special issue. I suppose my time is over, so I have to skip from this study. And then finally, I would like to talk a little bit about the China strategy in controlling further spreading. So as you know, we announced, including Professor K.Y. Yun, and we announced so that the definite human-to-human transmission, and also confirmed that medical staff have been infected at the day of 20th January. The central government had taken very strong action, lockdown Wuhan, so, and also mentioned about don't go to Wuhan, don't leave Wuhan, and the so-called real-time announcement of the number of the diagnosed and suspected patients every day in each city nationwide, and the so-called interagency mechanism launched. So this interagency action is down to the community, the so-called early self-protection, early detection, early diagnosis, and early isolation. So this is something happened in Wuhan at that time. I would like to mention about this because in Europe, in your country, that's still at the first wave. So we just take the action on the 23rd January, and reaching the highest just 2 weeks later, reaching the peak. And after that, it's going down. So eventually, after 1 month, 4 weeks, so they return to the basic control. This is one thing. And you can see here, so this is in China from the end of January to the just 2 weeks, and then reach the peak. Up to now, still is a plateau. But in some of the countries, you can see, so very low and very few, and then start to increase in the 7th of March. And then after that, that's 3 weeks, it's going up strictly. So this is what we have made a prediction. So this is, we are on, and also validated that in real time, that's the curve actually now happened. If we announce this, we give this strategy a little bit earlier, 5 days earlier, then we would like this. If 5 earliest late, then we would like that. So the peak will be 170,000 patients in China. So this is the real situation in Italy, the United States, Spain, Germany, Iran, France. So now still going up at the moment in this curve. I suppose we should have some action towards the very strict, so the lockdown, the high outbreak area, and then have a very strong, for early, the so-called self-protection, self-detection, self-diagnosis, and self-isolation. So thank you very much.
Thank you, Professor Zhong. Thank you very much. And we will leave the discussion part later. And the next speaker will be Professor Felix Hirth. Professor Hirth is going to talk about the current condition of COVID-19 in Germany. Professor Hirth is a well-known pulmonologist. He is the CEO and CMO of the Thoracic Clinic, Heidelberg University. He is also the head of Department of Medicine, Internal Medicine, Pulmonology, and Critical Care. He also serves as secretary for the European Association of Bronchology and Interventional Pulmonology. So now he's going to update us on the COVID-19 condition in Germany. Dr. Hirth, please.
So we are here in the bigger lecture hall due to the reason that we have to keep a distance of 2 meters between us to don't spread the virus. I hope you can see my slides now.
Yes, we can.
Okay, so just give you a quick update. We have seen that data already by the previous speaker, giving you a little bit an update what is ongoing in Europe. So these are the data we just got yesterday evening. This is the list of the European cities. For sure, Italy, we will hear later, is at the moment the country with the most infected persons or the patients. Then Spain. Germany is actually at the number 3. We have about 30,000 infected patients, and actually the actual death rate is a little bit higher. When you look to higher numbers, it's about 160 patients now who have died on the virus in Germany. These are the numbers in Germany during the timeline, and you see it seems a little bit that we reached a plateau by about 3,000 patients, but it's always a question how quick the information from a local lab that the patient is infected is reaching the authorities. So I'm not so sure if we really reached the plateau or if that only at the moment looks that we're reaching the plateau. When you look to the distribution of the infected patients through Germany, you see the red areas are the areas where we have a higher rate of COVID positive patients. And you see these are the south counties which have contact to France, which have contact to Austria. A lot of Germans went skiing in Austria 2 weeks ago, so we will see what happens when they now reach the 14 days. And there's also a bigger group in the middle of Germany where we have, which is the carnival area, where we have a lot of parties at the end of February, and also having a lot of infected patients there. When we calculating what we maybe have to expect using the experience we have from China, we have about 82 million Germans. At the moment, we have 30,000 infected patients. So the probability of illness is at the moment for Germans 0.04%, and nearly 160 patients died. So the mortality rate is 0.5. So it seems that from the numbers we have, Germany is at the moment in a little bit in the situation that it's not as severe than in other European countries. We maybe get the data later. What we're doing, this is the recommendation which patients should undergo PCR testing for COVID-19. So you should have new respiratory symptoms or unspecific general symptoms, and then you we must be sure that the patient the person have had contact to a patient who is COVID-19 positive, or the possible candidate is coming back from a so-called risk area within the last 14 days, and these are the risk areas which have been announced by our national authorities. So persons coming back from Italy, whole Italy, Iran, China. This is especially the Wuhan province, South Korea, France. This is the region Grand East. This is the region close to South Germany, Austria, a specific area, Spain. It's actually the capital. And from the US, California, Washington, and New York. When you're coming back from such a risk area and you have new symptoms, then you are getting the PCR testing for COVID-19. So the actual situation here in our area, you see the cities are not comparable to China, so therefore everything is a little bit smaller. We can do about 300 PCR tests for COVID patients per day. In our region here around Heidelberg, we have 407 patients. Yesterday evening, 66 of those have been hospitalized and 2 patients are on an ICU. 9 patients are on an ICU. 2 of those are on a ventilator, and we have to see what is ongoing. From the treatment, we following what the Chinese colleagues showed us. We're starting with the chloroquine, we're putting the patient then on Kaletra, and then we hope that everything is going in the right direction. What Germany did quite early, Germany is shut down like the Hebei province, and we're hoping that by shutting down Germany, so the school activities are stopped, social activities are more or less stopped, that we can keep that wave we are expecting in a level that the capacity of the hospitals can deal with the problem, and if we do not running in a situation of non-controlled spread where we cannot really keep everything under the medical, keep the patient in the medical system. So hopefully that shutting down of Germany, what China already did, and China already showed us that it seems to working, will work for Germany as well. But this was the German update. At the moment, what we're doing is preparation for the wave and doing a lot of prevention, that we hopefully having a smaller wave than in other countries. So that was my talk. Now I give it back to our chairman, to Bean Lam, who will introduce the next speaker.
Thank you, Felix. Thank you for updating us the current condition in Germany. And our next speaker is Professor Jonathan Van Tan from UK, and he is going to talk about the current COVID-19 condition in UK.
Good morning, colleagues. This is Jonathan here. Can you hear me? Over.
Yes, we can.
Okay, thank you. I don't have any slides to share with you this morning, and my talk to you will be relatively short, but I hope it will be clear enough for you to understand. In the UK, our policy in the first part of the COVID-19 incident was to follow a policy of containment to the extent possible. That is to say, the interception of cases, the identification of cases from abroad, from areas where there was already a higher degree of disease activity, contact tracing, and follow-up. And of course, it's impossible to say definitively, because we had no control group, whether this was an effective strategy, but it certainly felt as if we were controlling the rate of introductions for quite some period of time. I think we reached a tipping point in terms of the likely success, and indeed the material success of that strategy, when the case numbers rose very rapidly in Italy and in Iran. Both of those countries have very, very strong travel links for us, and we weren't in a position to close off those travel routes to the extent possible because of indirect travel, and also because of the sheer numbers of British citizens, for example, skiing in northern Italy. So that is, in a sense, how our epidemic curve has evolved. We are very much now at what we think is the early stages of an epidemic, with very significant rises in case numbers now. We have introduced, over the period of about 10 days, a series of increasingly severe and increasingly complete social distancing measures, to the point that where 48 hours ago the conditions we're under now are rules on case isolation, rules on household isolation. Say a rule where if there's a case in a household, an index case, the entire household is instructed to stay at home for 14 days. In addition to that, we have now introduced further measures which are fairly extreme social distancing for us, with the closure of all premises except essential retail premises, with instructions to all citizens that they are to work from home unless it is absolutely impossible to do otherwise, and that they are allowed out for one period of exercise in the open air per day, maintaining a separation of 2 meters from all other people who are not members of their household. They are allowed out to buy essential food supplies and advised to keep that down to a very infrequent food shopping trip. They are allowed out to collect medicines from a pharmacy or a GP surgery, and they are allowed out if they are looking after another person who is in total self-isolation. So for our patients with known severe comorbidities, particularly known immunosuppressive conditions or immunosuppressive medicines, we've introduced a policy of what we're calling shielding, where those individuals are not allowed out of their own homes for 3 months. They will stay indoors completely and be supported by authorities or by friends and neighbours. The people I said are allowed out for food. This is a policy that we only introduced 48 hours ago. We know from our ICU surveillance system that case numbers are continuing to rise, but in as much that the ICU cases that we are seeing are typically 10 to 14 days old, that is to say 10 to 14 days since their illness began, then we don't expect to see changes in terms of turning the curve in terms of our ICU figures for another 2 weeks. Now, in terms of the UK's health system, we're doing exactly the same as Germany in hoping that these social distancing measures will turn the curve, flatten the curve sufficiently for there to be enough bed capacity within our hospital system for the admitted cases. In particular, I think a pinch point in the UK is the availability of ventilatory and ICU care. There are measures underway within the health system. There were some plans before this all happened to be able to double the intensive care capacity of the UK system. That's well underway. You've probably seen on the TV that an entire conference centre has been taken over in East London. That is going to become a 4,000 bedded hospital very shortly. My anticipation is that within about 1 week, that new hospital will be operational with some military assistance. And we are preparing, I think, for things to get worse in the next 2 weeks before we hope that the curve begins to turn. We have already initiated a clinical trial in hospital patients. Great credit to my friend and colleague, Professor Horby in Oxford, who from a signal to go has produced an adaptive hospitalized patient RCT multi-arm in 9 days. That study has started recruiting patients. It's going to run in 138 hospital centres across the UK. The arms within the study will be Kaletra, lopinavir, ritonavir, supportive care, dexamethasone, and we're just adding another arm of hydroxychloroquine as we speak. We're also probably 7 days away now from a randomized trial beginning to recruit of high-risk patients. We're saying they should be over 50 with high-risk conditions, comorbidities, or over 65 irrespective of comorbidities or risk conditions, and these will be community patients who present with symptoms compatible with COVID-19, and we're planning an initial randomization to supportive care or to hydroxychloroquine with the intention that the endpoint of that study will be requirement for hospital care. So I think we're probably being quite innovative in seeing if primary care use of various interventions will be important in terms of reducing the requirement for hospital care. Finally, I would just say that there is the existing REMAP-CAP European study of various treatments, including Kaletra and interferon in ICU patients, that is ongoing and will continue. And we are looking at 14 other potential compounds at the moment that have been identified either through screening or through interested companies or investigators sending us materials. They're going into a formal process at the moment. It will take about another week. At the end of that, we hope to have identified a small handful, maybe 4 or 5 compounds that we think are worth taking forwards for preliminary evaluation, and then onto a full clinical trial. Quite a few of those compounds in the basket of 14 under evaluation are immunomodulatory drugs, including things like Roche's Roactemra. I'll stop there, and I'm very happy to take questions, and may I thank all colleagues on the call and say how valuable, because of the stage we're at in our epidemic curve, we find this scientific interchange. My registrar, Wickham Jayatunga, is on the call as well. I will just pause momentarily and see if Wickham has anything he thinks we should add. Over.
Nothing to add.
Okay, colleagues, that's the end of the UK delivery. Over.
Thank you, Professor Van Tam. It is very interesting to see if the early use of hydroxychloroquine in the community can decrease admission rate. This will relieve part of the burden on the hospital healthcare system. It will be interesting to see the study report. And the next speaker will be Professor Paolo Bonanni from Italy. He's a professor of hygiene and public health, and he is also from the Department of Health Science, University of Florida. Professor Bonanni, please.
Up to now in Italy, we have over 69,000 confirmed cases by PCR. The number of testing is almost 300,000 PCR tests performed overall in the country. We have presently 54,000 PCR positive, because the other were healing. more than 8,000 people were completely healing after the start of the epidemic. But we have a considerable number of deaths. You can see here 6,800 deaths. The epidemic is very concentrated in one region, which is Lombardy, which is the region of Milan, so the most active and the richest part of the country. There, about 10 million people live in that region. This is by far the most affected region of the country. Almost half of the positive cases are concentrated in that region, and they have 2/3 of the overall deaths. So I want to give you some hints, some possible explanations for the high case fatality rate in Italy, which is, as calculated some days ago, around 80 per million inhabitants. Compared to other countries, this is much higher. And so what are the possible reasons for this? We have probably a more advanced course of the epidemic compared with other countries. That might be one explanation. So we were the ones who started, unfortunately, in Europe with a big fire that was not discovered until we had a considerable number of people infected, and that was probably by chance. So we cannot know, but probably from some other countries there is a theory that there was some contacts with the first case that was mentioned before from Germany, but we don't know actually. Then we also have a problem with the denominator of population on which the case fatality rate is calculated. So we have seen some figures comparing the case fatality rate in Italy with China, but we don't know. Probably in China it was calculated on the whole population of China. But depending on which kind of a geographical area you take, the case fatality rate can change dramatically. Then we have a problem with the average age of affected people. In China, it was reported that the average age of infected people was 51 years, with the majority of people between 30 and 69. It was between 20 and 29 in South Korea. And there were mainly women in a religious sect, which were affected. But in Italy, the average age of cases is 63 years, and the majority of people affected were between 80 and 89. We have an average age of dead patients of 80 years, and 48% of them have 3 or more chronic diseases which were pre-existing the COVID-19 infection. Then another problem is the available places in the intensive care unit and assisted respiration. Because of course, with so many cases altogether, we had the stress on the healthcare system. And now there is a difficulty in finding sufficient places in the hospital and in assisted respiration wards. Then the other problem was the spread of infection in healthcare settings and residences for the elderly. In some residences for the elderly, 1/4 of people living there affected died. So since we had the spread in those particular settings, that was a big problem. The other problem is the high average age of the population in Italy, which is one of the oldest population in the world. And the other problem is the policy of use of PCR testing, because in Italy it was decided to reserve them to some symptomatic cases, and probably this hides a much higher number of asymptomatic or slightly symptomatic cases. So in the end, when we will calculate all the infected people in the country, probably the case fatality rate will be much lower. And a particular situation was that the dramatically lower case fatality rate in the Veneto region, which started at the same time as Lombardy. And they used more widely the PCR testing, and they made a more thorough tracing of contacts of cases. The last slide I want to show you. This is one of the many mathematical models that are running in Italy today. It's a very simple model. It regards the region where I work, Tuscany. It was made yesterday, and it shows the real number of cases, which are the red dots, The pink curve is the average of the last 3 days, and you can see that this fits with the possible peak of the disease, which would be reached now, and so that is the light blue curve. It's the forecast for Tuscany. The dark blue line is the situation that was seen in Guangdong, the Chinese province of Guangdong, which seems very similar to the situation in Tuscany, in my region, which is less affected than Lombardy. And so the hope is that now we are at the peak, and that we hope that it will go down in the next weeks. So the final consideration, we probably reached the peak of cases at the country level, but what about possible spread to southern regions? The southern regions of Italy are still relatively with few cases, but we don't know if it spreads there, what could happen. Also because the health system is less well organized there. How long will we need to keep social distancing measures? At present, every economic activity except for food, drug, and chemical production and distribution is stopped in Italy, but this is a very hard situation also from the economic point of view. We need to wait until how many cases in which geographical area, so to release the distancing measures. So we don't know, and this might be a help from China. When did you decide to stop distancing? Even if we release the measures, will we need to put restrictions to travel from other countries in case of delayed epidemic peak outside the country? So if the epidemic curve is going down in Italy, but for instance, it's growing in South America or some other part of the world, should we keep these measures for people who travel? So there are a lot of questions that are open and for which the discussion might be very helpful. Thank you very much. I stop here.
Thank you, Professor Bonanni. Very informative talk, and of course also raised a lot of questions. Many of us want to know the answer, and also many people via the internet asking the same kind of questions. How long shall we keep this social distancing, etc.? So we will leave the Q&A session later for the hot discussion. And for our next speaker is Professor Fedi Cray from Romania, and he is going to talk about the current situation of this COVID-19 in Romania.
Hello, I hope you can hear me.
Yes, we can.
Thank you. So just a very quick update of what's happening in Romania. We are almost at 800 cases right now. So we are on the lower rate of number of cases, 12 deaths. And we are at the starting, I would say, of a quarantine in Romania as well. We have been practicing social distancing for the last 2 weeks. The schools have been closed 3 weeks ago. And since starting last week, we have been closing all the restaurants, shops, malls, and so on. So I would say Romania took very early the decisions of social distancing, closing the economic activity, and making sure that as many as possible employees work from home. If we look at the cases right now in Romania, we see that the majority of them, more than 90%, are people who have traveled outside of the country and returning mainly from Italy and Spain. And the government has tried so far to contain and isolate or quarantine these cases. In the last week, we've seen now community spread virus. So we have the first cases of the people who did not travel or did not be in contact for them. So, and we are seeing an uptake in testing patients. I think it is a direct correlation between the number of people who have been tested so far and the uptake, which is now getting to the, let's say, quite numbers of testing. We've been testing so far in Romania only 200 to 300 people per day in the entire Romania, only to the certain symptomatology. And now we are hoping to start testing much more. And we are trying to adopt as a country the model of trying to test as many people who are in urban areas and who are part of the, let's say, traveling community or business community. Also, starting today, the government has banned people who are older than 65 years old to leave their home. They can leave their homes only for 2 hours. So a certain hours between 11 and 1. And all elderly people are asked to stay in their homes and are apparently going to be monitored by the police and the army to stay in their homes. That would be the update from Romania. I would say that we are very, I would say, lucky to learn from your experience from other countries and trying to implement the best practices that we can here in Romania. So that would be, let's say, the strategy of the Ministry of Health and the strategy of the government.
Thank you, Professor Cray, for updating us the current condition in Romania. And I think because China is the first country to be hit by the COVID-19, and China is doing, I would say, very well in combating the disease. Therefore, next we will invite Professor Zhongnan Shan to talk about the strategy for anti-COVID-19 in China. Professor Zhong, please.
Yeah, if you please, the next, Dr. Zhong has finished the speech.
Oh, so that part of the information has been included in his previous speech. Yes, yes, I think that's correct. My mistake. So therefore, then I would like to invite you, Professor Li Shiyue, to talk about
another speaker from Italy.
Oh, I'm sorry. And yes, next we should invite Professor Bartoloni to talk about management of COVID-19 in Italy. Professor Bartoloni, please.
Can you hear me?
Yeah.
Yes, you can.
Oh, good morning from Florence. Thank you for inviting me. I will integrate information we heard from Paolo Bonanni, my friends and colleagues. I'm here with other colleagues from the Infectious and Tropical Disease Unit in Florence. Our experience here started the 25th of February. We housed the first patient, and now we have treated about 70 patients in our ward, and probably around 150 patients in the whole hospital. At the beginning, patients, of course, were housed only in the infectious diseases unit, but now we have other internal medicine ward dedicated to the patient due to the increasing number of patients admitted in our hospital. We have now 15 patients in intensive care unit and 24 in sub-intensive care unit. We are treating patients with lopinavir/ritonavir. The patient which have problem with interaction with other drugs or don't tolerate Calitra, we are using the combination of darunavir obicistat, another antiretroviral agents. We are adding hydroxychloroquine at the dosage of 200 milligram bis in diem, and at the moment we are not using any treatment in mild symptoms. This is a point we would like to discuss with you, because the strategy here is treating only moderate and severe cases, and we are discussing about the possible utilization of treatment before developing complication, although it would involve primary care services. We used remdesivir by compassionate use, and we used on 8 patients. 4 of them were intubated. At the moment, we have no possibility to use it because we are not receiving the antiviral agents. We joined the national study on tocilizumab, and we at the moment it was used in the patient in intensive care unit, intubated patients or severe patients. We are starting by using in our ward tocilizumab. In the last, we started in moderate, in not severe cases in order to prevent the worst complication. We didn't use corticosteroids, and we are discussing a lot on this point, and we hope to have elucidation suggestions from your experience. We didn't use interferon, we didn't use immunoglobulin. We are treating to organize the collection of plasma from convalescents here in Florence too. We are discussing a lot about treatment strategies because there is lack of clear results from trials. We are discussing about the use of antiretroviral subjects. We are observing a lot of supposed side effects. Diarrhea is a common event in our patients, and we are trying to evaluate the opportunity to use these drugs. We would like to be sure on the right dosage of hydroxychloroquine, and we would like to have more information on the combination of hydroxychloroquine with azithromycin. That is some recent data from the French group from Marseille reported a synergy between the 2 drugs. It could represent an oral treatment that could be available in patients, not hospitalized patients. We are interested also in knowing about the new drugs that was mentioned before. We are receiving a lot of proposals to use immunomodulant drugs, but we lack solid data, and we are not sure in implementing these options. I take this opportunity to congratulate to China's healthcare system. We admired your effort, and we thank you for being here today and offering your support to us. Thank you.
Thank you, Professor Bartolani, for updating us on the treatment regime in Italy. And actually, I think how to treat is still very challenging because we do not know what is the best drug yet. I also do have a lot of questions, and maybe colleagues in mainland China can try to answer all these questions. Regarding the mortality cases, actually these patients died from uncontrolled viremia, or they died from cytokine storm. If it's died from viremia, then maybe early treatment, which can decrease the viral load, might be important to decrease the mortality. On the other hand, probably then we should think about immunomodulation medications or even steroid when it's best timing to give this kind of medication to damp down the immune response. Maybe Professor Zhong or Professor Li, Professor Luo can teach us, enlighten us on your view on this. And for example, if now you have a new case with this COVID-19, newly diagnosed, just admitted on day 2 or day 3, what kind of treatment will you give based on the current evidence you have? Yes, colleagues from mainland China.
Well, Dr. Lam, is that another speaker will be speaking from the UK? Is that right? Based on the agenda. Welcome.
Actually, I think there will be 2 more speakers. One is Professor Li Xuyue to talk about how to safely do bronchoscopy in COVID-19 patients, and also Professor Luo Fengming to talk about how to diagnose and how to have a best personal protection for healthcare workers. We yeah. That's we have 2 more speakers, and yes, we can then follow the agenda at the moment and have a discussion later.
Maybe better.
Okay, let's just follow the agenda. Then Professor Li Xuyue, please kindly advise on how to safely bronchoscope COVID-19 patients.
Today my talk is the bronchoscopy in patients with COVID-19. I will focus on this field. First, I would like to talk about the general principle for bronchoscopy in COVID-19 patients. In the early February, Chinese doctor joined together and have a consensus for bronchoscopy during the epidemic of COVID-19. So the key points for conducting the bronchoscopy on patients with COVID-19 is the highly risk procedure in which healthcare are directly exposed to the virus. So the indications for the bronchoscopy for the other diseases should be strict mastered. And the bronchoscopy should not be used as the routine means for the diagnosis of COVID-19 infection sampling. And the personal protective equipment, PPE, is required during the procedures. So here's the PPE is the equipment PPE during the bronchoscopy. And here's the procedure I did in my hospital. And so for the bronchoscopy in the COVID-19, one indication is for the incubations. We did the 12 case during the January 20 to February 19 in the hospital, in my hospital. So this 12 case was confirmed COVID-19. All 12 patients were successful incubated under the guidance of bronchoscope. And the health workers were protected under the PPE with the positive pressure protective hood. The time of the procedure was about 2 minutes for every procedures. For all the procedures, no complications, and there were no infected for the 9 health workers who involved in the incubations. So I think the bronchoscopy in COVID-19 is for the incubation. And for the diagnosis, we in some cases, if we are very need to look at the airway, and we can do the bronchoscopy. Here, some cases we are did in the COVID-19. It seems that the mucosal was hypolemia and swelling to the mucosal, and there are very small amount of the secretion for these cases. And more common is for like this, the smooth bronchial mucosal and the clear lumen and little secretion like this. Most of the more common is for in my practice is like this. And for some instance we can use the bronchoscopy for diagnosis. Here's the Princeton paper. It was dated in Shenzhen, China. Here we can see use the different sample we can share with the throat score and nasal score and sputum and buffer. For the severe patient, here we can see for the periods of 8 after onset days 8 to 14. Here we can see the BAF is the most highest sample. It's about almost 80 to 100%. So I think for some instance, if we need to see is that the real COVID-19, we can use the BAF. And here's another case in my hospital. It's the male 19 years old male. 2 weeks after onset, the patient was received the clinical ventilation with the high airway restriction and hypocapnia. After Dr. Jones looked at this patient, he asked we to did the OCT, optical coherence tomography. Here's the machine, and here's the procedure we did. You can see here's the different index, lumen diameter and the lumen airway, also the wall airway and airway percentage. So for this case, the RB8, here the lumen, general bronchial general 3 and 6 and 9. And here's another bronchial, LB8. Here we can see from the longitudinal section. You can hear the lumen is similar. This is the normal subject. Here's this case RB8 and LB8. We can see here the airway is similar, but you can see here the secretion for this case is much common in the normal subject. Let's see the lumen airway. Airway is similar compared to the normal. Also for the airway wall area percentage is also the similar. So for this case, we finding that there's no significant decrease in the lumen airway of the bronchi of grade 8 to 9. Also, similar finding for the bronchial wall of grade 3 to 8 to 9. But we can see the mucus retention occurs at the most of the bronchi of grade 4 to 6. Also, for the treatment of the bronchoscopy, we can clear the airway, clear away of airway secretion and BAF. Here's some report in the news that before the bronchoscopy, we can see here the line here. Up 2 hours after the bronchoscopy, with the 11 excretion eliminated by bronchoscopy. Here we can really clear after the bronchoscopy. And here's the case by treatment by our colleague, Dr. Sun in Wuhan. Now he's working in Wuhan. This is the chest before the bath, before the lavage, and 4 days later, after 3 times the bath, we can see it's much clearer than before. Yes, the buffer. And this is the case Dr. San was treated. We can see no much secretion in the airway. But for the further airway, we can see some abnormal in the like this, maybe some infection for the small airway, for the further airway, in the further airway. And here we can see some very sticky secretion inside the lumen. And last, I'm talking about the equipment. Here, the equipment that we are used is the video, portable video flexible bronchoscope. Is very convenient for the procedure, especially on site. And we can use the single-use flexible video bronchoscopy. Here's the bronchoscopy. So finally, I would like to sum up a summary. Bronchoscopy on patients with COVID-19 is the high-risk procedure. So the personal PPE is required during the procedure. In some cases, bronchoscopy has unique advantage for the treatment and diagnosis. Thank you.
Thank you, Professor Lee, for the excellent talk. And it's very brave of you and colleagues in mainland China to do bronchoscopy in COVID-19 patients. Congratulations to you all, and you are safe after the procedure. That's very good. And our next speaker is Professor Luo Fengming from West China Hospital. He is a professor there, and he's also the Deputy Director of the Department of Respiratory and Critical Care Medicine. He worked in Wuhan for 2 months during the epidemic there, and now he's still self-quarantined at home. Today, he's going to talk about the clinical diagnosis of COVID-19 and also what are the appropriate personal protective equipment in order to protect medical health personnel. Dr. Law, please.
Okay, can you hear me?
Yes, we can.
Yes, the single-use bronchoscope we also used in Wuhan. It's very useful for us to not only diagnosis, but also treatment for some patient. You should put on the PPE according to the instruction of the Professor Lee. Okay, I want to talk about the diagnosis and the personal protection of the about the COVID-19. And I just want to talk about diagnosis and the personal protection. First, for the diagnosis, and we also know that the transmission is by droplets and contact, sometimes aerosol in some occasion. And we classify infection the COVID-19 to simple infection, middle pneumonia, severe pneumonia, ARDS, sepsis, and septic shock. Also, there's a pathology changes. It's very important for the inflammation and the mucus. Sometimes the mucus can lead to the respiration failure and increase of the PaCO2. And so sometimes we use the bronchoscope to watch the lung. We should ask the history of epidemiology. As I mentioned above, the incubation period is 1 to 14 days. So we should ask the patient about the history. And sometimes the family members get the same symptoms, and so it's clustering. As to the symptoms, I think the fever and dry cough is very common. Nausea, congestion, runny nose, and sore throat is not so common in clinic. Sometimes the diarrhea. Diarrhea may be due to the infection of the virus, but sometimes maybe just due to the medicine. For example, the Abidol can cause this kind of diarrhea. In severe cases, dyspnea is very common, and maybe within 1 week of the onset. But some children relieved very quickly, just 1 or 2 days. We also use the electronic stethoscope device to hear about the breath sound. You can see that some patients have wheals and also crackers. Most of them locate at the base of the lung. You may ask why we use the electronic stethoscope device, because we put on the personal protective shoe, so we can not use the usual stethoscope. As to the laboratory testing, blood routine examination always showed normal or decreased of the neutrophil, and lymphocyte count decreased. As to the inflammatory indicator, CRP and D-dimer may be increased, and sometimes L6 increased significantly. As to the disease progress, lymphocytes decreased progressively. And as to the various detection, at first the specimen, we can use the throat swab, nasopharyngeal swab, or anal swab. And we also use the sputum. And as mentioned by Professor Lee, also BAF can be used for detection the RNA. The sample should be tested within 4 hours. If you cannot test it within 4 hours, maybe you should store the samples in 4°. Now, if you want to preserve for longer time, you should put them into the lower condition. We'll use the RT-PCR or sometimes use the next generation sequencing for the test the virus at the same time. Which one is the better one, nasal swab or pharyngeal swab? We investigate that in 100 patients. We can see here, we use the Lennon-Flocking swab for nasal swab. There's almost 90% positive, but at the same time, we'll perform the pharyngeal swab. It's only almost 50%. So we usually use the nasal swab for detect the virus. Also, the antibody for the virus, IgM may be increased, and within 3 or 5 days, and also IgG increased significantly. And as to the CT scan, in the early stage, maybe small patches and interstitial changes. After that, it developed into multi-ground glass opacity. After that, maybe the lung consolidation may be found. In the recovered period, ground glass opacity may be appeared again. Here's a case with a female, 42 years old, with fever and cough. But you can see here, the X-ray is normal. But at the same time, we perform the CT scan, and you can see here the small lesion and under pleural, and here. And 4 days later, and the GGO is increased significantly. 10 days later, maybe the patient recovered and the symptoms improved a lot. And as to the diagnosis, the suspected patient, we also ask the history of epidemiology and also the symptoms, fever or respiratory symptoms. Also, CT scan can tell us if it's there's a lesion over there. And the blood test, if we have the history of epidemiology and also the clinical manifestation, we can maybe make a suspect diagnosis. But we should exclude other pathogens for the infection of the lung. If we can find we can confirm this patient by RT-PCR or some other method for detect the virus, also some maybe antibody for it. Maybe sometimes we doubt about the CT or nucleic acid detection, which one is better. At the first, the nucleic acid detection took longer time than now in Wuhan, so it took a longer time. So some doctors said that we should use the CT scan, but the CT scan have a high sensibility but lower specificity. So I suggest that clinical laboratory testing and the imaging put together can make a better diagnosis for the patient. And as to the classification, we classify in middle, common, and severe patient, also very critical type, well familiar with it. And as mentioned by Professor Zhong, there's some parameters tell us that the patient will progress very fast. For example, lymphocyte decreased, and also IL-6 and CRP increased significantly. Also, lactic acid increased, and also lesions on CT progressed rapidly. That means that within 3 or 5 days, in a short time, the CT progressed very rapidly. All this may tell us that the patient will become critical. And some risks for the patient to become critical. The age older than 65, obesity, if the BMI greater than 28, if the patient has COPD, IPF, CTD-LD, also chronic heavy smoking, some hypertension, and nervous system such as cerebral infarction, also CKD, this patient is very dangerous for progress. So right now, this virus is very crafty, I say. we don't know enough about it. Sometimes clinical symptoms is apparent, but nucleic acid is negative. CT change is obvious, but the nucleic acid is still negative. Sometimes low clinical symptoms, nucleic acid positive. Clinical symptom disappeared for a long time, but the nucleic acid is still positive. It's very common in the patient with type 2 diabetes. Sometimes citizenation completely absorbed, but the nucleic acid is still positive. So it's a challenge for us. It's also some differential diagnosis. It's as to the personal protection, I think the quarantine measures, including respiratory droplet isolation, contact isolation, or aerosol isolation. We used a lot of personal protective equipment, PPE, for respiratory protection, eye and face protection, and the trunk and the limb protection, also hand and foot protection. And it's a standard protection and enhanced protection. We can see use the cap and glass and face shield and N95 and also protect shield and this kind of things, and gloves. And additional protection is just like we perform the bronchoscopy and we use the positive pressure head cover here. So let's we should put on cap first and then test, put on the masks and test it and put on the protection shoes and outer protect clothes and put on the outer gloves and also put on the face shield and sometimes use the boat and you should check the wearing. And it's the what I was locked in the ward. And after the finished the working, we should remove the face shield and take off the outer clothes and then the inner clothes shirt and maybe a ring and the masks and then the cap. And the hand hygiene is very important and we should wash our hand carefully. So you should protect yourself and then you can help more people. You can see here that the January 25, we were in the airport of Chengdu, and in March 21st, we returned from Wuhan to Chengdu, and we have 20 doctors and nurses in our team. After return to Chengdu, we tested the nucleic acid for the virus. All of us have the negative test. So protect yourself, take care. Thank you.
Thank you, Professor Luo, for the excellent summary regarding the diagnosis and PPE. And now we shall proceed to the discussion part. I guess we have a lot of questions, and Professor Corbetta and myself will be the one to deliver questions we received from the internet, and those maybe some questions are raised by ourselves. Professor Corbetta, please. Do you have any questions you would like to ask first? Yes, it's still mute. We can't hear you now.
Okay.
Yes.
Thank you very much. Very interesting presentations. My first question, but I received the same questions from many friends, many colleagues. Is the problem of the health workers. Because in Italy, especially in Lombardia, we have many infected doctors. 10% out of all the infected are doctors or nurses. And in United States, in Ohio, 16% are infected. How do you solve this problem or face this problem? What are your suggestions? It's a question for Professor Zong or the other presenters.
So, excuse me. So you are asking how to protect the medical staff from being infected?
Yes.
Yes, and how to organize the distribution of the patients to prevent that all the patients go to the hospital.
Well, I think first of all, I think in the very beginning in Wuhan, I think there's quite a huge number of the physicians have been infected. So up to now, I think similar close to 3,000 medical staff been infected, but the majority of the patients were in Wuhan at that time because there were terrible lack of protective equipment. So that's the main questions. And also the like in Italy, I suppose the physicians really exhausted because 24 hours working, so they're very tired and without any rest. So that's one of the reasons. So and then I suppose after 1 month or something, so they are altogether 40,000 medical staff going to support Wuhan, so then they can have a rest in turn. So that will make it much better to recover. And then there are enough number of personal protective equipment for them. I think it's extremely important, as Dr. Law just now had mentioned about from Wuhan. So and how to use that. I think that since then, very few medical doctors have been infected. So I have not heard very few. I've not heard any more than 2 or 3 so been infected. So the personal protective equipment is most important for us. I don't know whether that's the question or not.
The problem is that we realized that in Lombardia, many patients were cured inside the hospitals, and this increased the number of infected doctors, but not only, but also their families, and also to favorite the spread of the infection.
Yeah.
Yes.
Yes. I take the point. So I think that's a very important point that you have mentioned. So I think in some of the countries, including the beginning in Italy, so the government or the CDC are only focusing on those who had symptoms. So including the medical staff who have symptoms and who should receive some check-up. And I don't think they pay more attention to the close contactors. So their families, their relatives, and close contactors sometimes most important as a transmission route. So I think from our data have been shown 2 points. First, a asymptomatic patient, or perhaps it's just called that virus carrier. That's very infectious. They're very contagious. They transmit in the very beginning. So that's the second point is as just now I mentioned about it. So at the very beginning of the onset, so people are infected, and then the virus load is pretty high at the early days of the onset. So sometimes the symptoms just appear, or the symptom had not appeared, and the incubation time, it's very, the infectivity is pretty high. So in this moment, very easy to transmit to the others, including the medical staff, their relatives, their families. So that would be a vicious circle for the family or for the society. I think I've read from the newspapers, I think in Rampardo. So that's although it's closing down, but inside the society, in the community, people still join together, and then have a dinner and a meeting and even banquet or a party or something. So that's a very important way for cross infection. Although this patient had very few mild symptoms and recover quite well, however, he actually transmit to the others. So some of the persons, as you mentioned, I was not aware in Italy that the majority of the patients who die are at the age of 80 to 89. So I suppose it's reasonable for that high mortality, because those patients as I should say immunosuppressed person. So yes.
Thank you.
Yeah, I also we should also pay attention to the staph infection, because it's just not in the hospital, but sometimes outside the hospital. For example, in the Red Cross hospital in Wuhan, where I worked, some nurses infected outside the hospital. It's the first things. The second, and most of the staffs of the hospital stay in a hotel, not to live together with the family. So in Wuhan, we can not transmitting the virus to the family members, and also infect by the members of the family. So it's different from maybe from other countries. That's what I want to say.
Yeah, I would like to add another point in addition to Dr. Law. And I think when I was in Wuhan and the middle of January, so I met some of my students and some medical staff. So actually they were infected, but they are not in the department of infectious disease. They're not aware about that infectivity of this kind of disease. Some of I think the first part, cluster infection the doctor was the doctor from the Department of Neurosurgery. So 13 medical staff being infected by patients. So they have no knowledge about this. So I think in Italy, in some other places, that's most important. It's not only should be aware in the Department of Infectious Disease, but also in all part of the department in the hospital. Yes.
Yes, the other department, for example, in the Red Cross hospital, the oncology department, the doctors and the nurses are all infected by the virus, but in the respiratory department and also the infection department, no doctors, no nurses infected by the virus. It's very important. Yeah, they put on the mask always. Yeah.
Yes, because of the pandemic, many doctors are now looking after COVID-19 patients, and based on the available drug trial data, do you think, is there any role for medication as a prophylaxis for the dirty team, healthcare professions, such as hydroxychloroquine based on its low side effect, etc.? What is your idea, Professor Zhong?
I don't think there's any evidence showing that chloroquine or hydroxychloroquine will have some prophylactic effect in preventing those medical staff from getting infected. So just now, I think, so Professor Bortonali from Florence, is that right? am I pronounced correct? Bartoloni.
Bartoloni.
Yes, yes. Bartoloni. Sorry about that. I think you had mentioned about been using hydroxychloroquine in your patients or something, and also I think another doctors just use 200 milligrams twice a day. I think from our study just now I have shown. So we use 500 milligrams twice a day for 10 days. So we have follow up the blood concentration of chloroquine. So the highest concentrations 1.6 micromoles, and this kind of blood concentration is enough to kill the virus. However, it's far from reaching the toxic window, the toxicity window. As you know, that the paper from the New England Journal of Medicine in 1988. So that's just describe some of the patients who took the chloroquine to commit suicide. So the average blood concentration is close to 20 micromoles. It's far from reaching that. So we suppose our conclusion is quite safe. So when we have been using for more than 20 patients, and now the papers have been summarized and then submitted. So the blood concentration is very safe. So from the Massachusetts General Hospital, their guideline for the for subjection of using hydroxychloroquine. So because hydroxychloroquine, I've not seen any clinical trial for the management of new COVID, but they had some. We have done some in vitro study in the P3 laboratory, and have found they actually had the similar activity in the antivirus activity as compared with the chloroquine. So it seems to be maybe useful instead of that. I suppose their recommendation dose is 400 milligrams twice a day for 2 days, and then 400 milligrams once a day for 5 days. So that's their recommendation. I suppose there may be some reasonable data to do that. But so far as I know, up to now, I don't think that there's any multi-center, not on control trial looking at the hydroxychloroquine. Anyway, I'm confident of the chloroquine in the management of this. But whether they have some prophylactic effect, I actually don't know. I have no idea about that. Dr. Lam.
Thank you, Professor Zhong. And then regarding to those mortality cases, whether they died from uncontrolled viremia or due to uncontrolled cytokine storm, if we could know the reason, then maybe we can tailor-make the treatment accordingly.
Yes.
China,
yes.
Italy, yeah.
Yes and no. So because we have performed lung transplantation, so for those patients who had already shown negative PCR reaction in several times, but when we perform lung transplantation, we actually have found there are some virus still in the lung. So not, I mean, in other words, so the sputum or the respiratory secretion, the virus doesn't mean that disappear, or the virus doesn't mean disappear in the organ. But however, so the majority of the patient actually in the late stage, in some of them, it just had viremia, still had viremia. And quite a big number of them actually had a negative PCR test. But the organ damage still progressively. So I suppose both cytokine storm induced organ damage and so viremia. So that's damage caused directly by virus. Both exist. So in other words, we need to have a two-part of treatment. So antivirus and anti-inflammatory information.
Thank you.
May I ask on your experience, Professor Zong, if there are some sequelae after months in the lung, fibrosis or reduced function of the lungs in the patients with the pneumonia?
You mean fibrosis?
Fibrosis after 1 month after the pneumonia. If there are some sequelae.
As far as I know, so it doesn't like SARS. So I have some experience for SARS. In the late stage of SARS, as fibrosis is very apparent. But in those patients with new COVID-19 infection, although the CT shows consolidation, and of course in autopsy shows some fibrosis. But in a recovery patient who recover from ECMO, from ventilation, so for a long time, say like 1.5 months, when they recover, I think the fibrosis seems to be at least partly reversible. So from the biopsy, it seems to have a lot of myofibroblasts and fibroblasts. So as you know, myofibroblasts at the early stage of fibrosis. So I'm not too much worried about the lung function when they recover.
Yeah, so we have two very almost 40 years old patient. The CT is very, very severe, worse, and after recover and improved a lot. And the patient, I think it's regeneration is very strong of the lung. Yeah, so just like Professor Zhong said, don't worry about this patient, the lung function. Yeah.
And regarding to slow down the progression of the disease, social distancing seems to be very successful, and lockdown Wuhan well demonstrated that. But eventually, this policy will be stopped, and how to prevent surge of the so-called second wave or third wave of the attack.
I suppose the way of prevention, both in Hong Kong and the mainland of China, it should be focusing on those persons who are importing. So the importing patient. So I just give you some example. Some of the persons who come to China, so from an epidemic area. So although they have no symptom, the nasal throat show very strong response of PCR, positive RNA test. And we have found there's no IgM at that time. So we give them some, move them to the fixed, appointed hospital. After the few days, I think over 3 days, symptoms like fever develop. So in other words, this kind of patients very effective. So this is the main thing. If we can stop, we can block this kind of import. So, or as to have more attention paying to that. We just have now, we started a double check of those so-called healthy person without symptoms. So after 7 days, maybe we have another check. And if it is okay, we suppose there's no need for 14 days quarantine. That's our thinking way. We try to get the approval from the government. So now we were still doing that. So because we are just make a comparison and see the peripheral blood, whether the peripheral blood and from the venous blood, the result are the same as a comparison. So far we have found that the result is similar. So we can just take a peripheral blood, which is quite easy to get. So I think the main point you raised is to prevent from the second wave. I think still need to keep this policy and then to focus on importers.
And I've got a question from India to Professor Zhong. What are your predictions for India being one of the most populated countries?
Well, it's difficult to me to say that. I think in India, I think it's not that serious. I mean, the situation. However, I think in India, you should pay the same attention to have some restrict stipulation. So as you know, so India, the weather is pretty warm, and in a warmer area, I mean, usually the virus is not easy to spread, but that's not the main thing. So in India, I think I have found the president also had set up some law, and then to try to close the high epidemic area, and then to try just to keep distance of the people. So just now, I think I forgot which one has mentioned about how long would that be? So in Italy, I have a tracing. If in Italy can tracing the close contactors, I think the future will be okay. So your increasing number is from the 1st of March and to the 20th of March. That's 3 weeks. And then you suppose will be going to the peak. I suppose will be. But if you can keep this stipulation, and then usually, so 3 or 4 weeks, will be going to the plateau and then going down. So in China, because we have been taking a very strong action. So we just within 2 weeks to go into the peak and then going down. So I suppose in Italy, I'm not too much worried about it. If you can keep this law or stipulation, then I suppose now is it going reaching the peak. Perhaps it will last for another week or some days, and then we'll be going down. That's my prediction. But anyway, I cannot predict exactly what will be happening in India. No.
Thank you.
Thank you. May I ask the last questions, maybe, that I received from UK and infection do offer protection for further infections? What is the duration of immunity? And there is the possibility of relapse.
Vaccine. Is it vaccine?
No, it's actually
No.
after you got the
infection.
What is the duration of the immunity from the previous infection?
Oh, I suppose, for example, IgM will be coming out within 3 days of the onset, and then going up, and then last for another 10 days, and then going down. And IgG will be going up, and in 1 week, and keep going up for another week or so. So usually in the mild patient, sometimes 2 weeks. So the majority of the patient. even you have no any treatment, but there's no any evidence showing those persons who infected with COVID-19 without any treatment will be recovered spontaneously. But it is the fact. But nobody had proved that so far. Nobody dare to give no treatment to those patients and just see the natural cause. Nobody had done that. So I cannot give that conclusion. But anyway, as far as the duration is concerned, I suppose maybe 2 weeks or a little bit more, right?
I mean, for those patients who got the antibody, are they protected from second attack? Will they get reinfected if they encounter the virus again?
In the majority of the patients, I suppose definitely yes. If they improve something like four times higher than the normal usual level. So I have not seen any patient who would get reinfected with such a higher serum antibody. There's no way to do that. No.
And then only just one strain of COVID-19 at the moment, right? There's no any antigen shift or drift yet, right?
So far, I don't think they are. And also, I think I read the paper, so there's some mutation of the regimen. But that's nothing to do with the N protein and polymerase protein, in which two is detected by the routine PCR test. That's nothing impact to the PCR, the accuracy of the PCR.
Okay.
An information, we have reached 60,000 participants in the middle of our teleconference. 60,000 participants, and maybe more.
Right.
And maybe one last question for Professor Luo. Is there any pharmacological or ICU management suggestion for mild, severe, or moderate COVID-19 diseases? Any strategy regarding the management of ARDS in these kind of patients?
It's almost the same as the regular ARDS, and sometimes in very severe critical cases, we use the large dosage of the steroid. But in a very short time, and you maybe in the early stage of the onset of the disease, it's maybe helpful. But we still monitor the bacterial infection of the lung in the ICU. Sometimes the bacteria are resistant to most of the antibiotics, so we should pay attention to it.
I suppose that up to now, the only effective treatment is convalescent plasma. So at the moment.
Yeah, that's true.
Jonathan here. Sorry.
Okay, do we have any?
Yeah, it's Jonathan here from the UK. I wanted to ask colleagues around the world if in terms of their clinical cases that they have seen, if they are picking up any meaningful or significant signal in relation to bacterial secondary infection. Over.
I think that's a very good question. I have noticed about this. So our routine culture from the blood, either from the blood or the sputum, it didn't show very apparent bacterial infection in this kind of COVID infection. So either in Wuhan or in Guangdong, in my hometown, I didn't find this typical secondary infection showing like another Bomani or some other Klebsiella or some others. So, however, I mean, a lot of fungus infection, but it doesn't show very clear. So you can isolate some typical pathogens in this kind of patient. Usually seems to be a predominant phenomenon, and very few. So I have never isolated any pneumonia streptococci. So never. So I don't know why, but really need to make it clear. So one of my group is doing some work on that. So some people may complain about why there's no any typical pathogens or bacteria being isolated from those kind of patients. And they said maybe this patient received a large amount of different kind of widespread spectrum of antibiotics at the very beginning. So both towards gram-positive, gram-negative, even fungus. But that's not the main question. I think maybe some other reasons. So that's what I can say.
Great. Do you have any other questions which you would like to ask? Yes, no? If not, then very good. Thank you all for joining this, and it's a very good platform for change of knowledge, especially for such a new disease as we know very little. And I hope all of you in good health in this fight against the virus. Thank you.
Okay.
Thank you.
Okay, thank you. Bye-bye.
Thank you.
Good luck.
Bye-bye. Bye-bye.
Bye.
Right.
Bye-bye.
Thank you. Bye.